Welcome, everyone, to our Anesthesia Journal podcast. I'm Ed Mariano. I'm an editor of the journal, and this is an American takeover of your usual programming. I'm joined by our guest co-host and my good friend, Dr. Jinlei Li. She's an associate professor of anesthesiology, and she's the director of regional anesthesia at Yale. She's also the vice chair of regional anesthesia and acute pain medicine committee for the American Society of Anesthesiologists. Great to have you here with us, Jinlei.
Thanks so much for having me, Dr. Mariano.
Our panelists today are Drs. Nasir Hussain and Faraj Abdallah, authors of the paper Association of Peri-Operative Prescription of Non-Steroidal Anti-Inflammatory Drugs with Continued Prescription of Opioids After Total Knee Arthroplasty, a retrospective claims-based cohort study. This article is currently available online and free to read from the journal. Dr. Hussain is an assistant professor of anesthesiology and pain medicine at The Ohio State University. And Dr. Abdallah is an associate professor of anesthesiology and pain medicine at the University of Ottawa and University of Toronto. Thank you so much for joining us, Nasir and Faraj, and welcome to the podcast. Well, yeah, I think with the time that we have, I thought we would just jump right into the discussion of this article. Just before we jumped on this particular podcast and interview, we were commenting on how much robust discussion there has been on social media. And I do think that it's very warranted. I think that nowadays, when we publish articles, we expect that the post-publication review process is ongoing. And it usually sparks a lot of discussion, especially about topics we care about. I think one of the big topics that we've all been very aware of for those of us who work and live in North America is the risk of opioids. And we've been very aware that this has become a matter of public attention. We have greater emphasis on the use of multimodal analgesia, and that includes non-opioid analgesics like non-steroidal anti-inflammatory drugs or NSAIDs. What made you guys choose this particular topic to study?
Yeah, this seems to be going upstream rather than downstream with respect to finding problems with the use of one component of multimodal analgesia. Both Nasser and I are regional anesthesia researchers and avid practitioners of regional anesthesia, and we're also chronic pain physicians. We're also strong proponents of multimodal analgesia and regional. And for us, this particular population, knee arthroplasty, constitutes a very interesting research focus because of being one of the most commonly performed surgical procedures, orthopedic ones. And with 30% of the patients developing chronic pain after surgery, of whom 13 to 16% become opioid dependent at around 3 months post-surgery, which is a significant clinical burden for patients and for the healthcare systems. And as a patient, you would go into the surgical procedure assuming that the outcome would be getting rid of pre-existing osteoarthritic pain. Nonetheless, paradoxically, a few of the patients end up with chronic pain and opioid dependence. So this is an interesting area of research for us. And the second, I think, reason that prompted us to look into this is the landmark publication by Parisian and colleagues and their novel preclinical data describing an association between NSAIDs and chronic pain. And that was quite fascinating, almost too good to be true. It was preclinical, so I think the first reaction is, okay, is this reproducible? Can this be a similar situation in human beings, considering that we see a lot of chronic pain after these surgeries? And the potential that the medication such as NSAIDs, which is routinely given to treat acute pain, to be associated with chronic pain is admittedly fascinating. It's an area of research that is novel, impactful, and probably practice changing. So that's another main attraction for us. And I hope with our work, we helped maybe partially address some of the questions.
It really pushes us to assume the equipoise approach, yeah, for sure. Nasser, any other additional comments related to the background and why you decided to do this?
Yeah, I mean, I think Dr. Abdallah touched on it very nicely. I think for us, many people know we've been doing knee research for a long time. Lots of our work's been focused on the analgesic modalities, the regional blocks that can be used for knee surgery. And now we're transitioning more into these multimodal agents and really investigating with evidence, because we're all evidence-based medicine physicians, how much benefit each of these actually has, and if we're actually possibly causing downstream negative consequences. I think the Parisian study is nice because it paints a picture that maybe when you're blunting the neutrophil response, you're creating an aberrant inflammatory response that the body naturally wants to have. And then because of that, you're causing a reframing and possible chronic pain development when you're blunting that inflammatory response. So that really stemmed for us. And this was actually a WhatsApp conversation with Dr. Abdullah. He shared the paper with me and he's like, what do you think? And we talked about this and we felt that this is something worthy of investigation. These multimodal agents that we're giving patients, we really want to see if there's a signal to a benefit at the end. Things like ketamine, lidocaine, NSAIDs. And for us, NSAIDs was very popular just because of this paper. And we felt, what's better? We need large numbers. We need large numbers of patients. What's the best step to see if there's any sort of signal that could be seen here? And that's when we thought about a database type question for something like this.
That's really interesting. I know Faraj and I had a chance to write a little bit about multimodal and this idea of just throwing the kitchen sink at everyone. So that's actually what made me think of your paper when I was handling it. Thank you. Jinlei, over to you.
Yeah, first of all, kudos. You're challenging the status quo. You're entering the precisional medicine. You're challenging what we take it for granted. We practice every single day. This is really going to have far-reaching impacts into our practice, and you link in the preclinical data into clinical practice. But how do you think the NSAIDs could be responsible for greater transitions of acute to chronic pain or greater long-term opioid use?
I think that's a great question, Dr. Leah. And that goes, again, back to that preclinical work by Parisian and colleagues that was just published. And what they find is that when you're giving NSAIDs, at least in the in vitro models, genetic models, you're seeing a blunting of the neutrophil response. So when you see that blunting of the neutrophil response, that's typically what you see in even patients for acute inflammation. You see a pronounced neutrophil response initially, which then subsides, and then the healing process is hopefully complete. By giving NSAIDs, the thought is that, are you blunting this neutrophil activation? And when you blunt the neutrophil activation, are you theoretically then putting the patient at risk of having just a state of chronic pain because they're not properly healed and the inflammatory response has been blunted? So that for us is the possible reason why these patients may develop chronic pain afterwards and then chronic opioid consumption or chronic opioid use. I don't know, Dr. Abdullah, if you have any additional thoughts on that.
I think this has been adequately addressed here, and we think of inflammation as something bad, and we're focused on suppressing it, but it seems this is part of the normal healing process, and this is a new philosophy that we're just starting to get our heads around.
Yeah.
Maybe these natural biological processes are something that we shouldn't interfere with and this is just preliminary speculation, and I don't have more evidence than what we have presented in our database review, but I think additional clinical trials are what will be able to definitively answer this question about the role of inflammation.
It really made me think, many of us, we're all familiar with the concept of the Starling curve and how there's like a right amount of volume. And it makes me wonder whether so many of our processes have a right amount. And sometimes we do interfere. Sometimes that's the right thing to do because we know that maybe inflammation gets out of control. But I absolutely agree that, I mean, we know that inflammation is part of recovery, it's part of healing. So many of our processes, I mean, literally from the healing of cuts and wounds and incisions and bones are very dependent on many of these processes. Looking at this question, you mentioned the preclinical data, and with your project, and I know that you two are experts in this form of methodology, but you employed an existing claims-based database to investigate this question. So how and why did you choose this particular study design?
I'd start by saying that I'm a trialist by training, and most of my expertise are in the area of designing clinical randomized control trials, and the RCT is my preferred research design and favorite source of evidence. However, the clinical trial might not be the most appropriate design in certain scenarios, and one of the alternatives would be observational cohort studies, including database analysis. And some of the scenarios are examining rare outcomes where an randomized control trial might require huge numbers and incur a big cost, which could be a precluding factor. Also, examining harm or undesirable outcomes. And we cannot design a clinical trial to look at harm as an outcome. It's always our aim to improve patient outcomes. And also, maybe a third scenario would be using this type of database research as a prerequisite to a future RCT to check for a certain signal in the noise and also help estimate the treatment effect, which would help you estimate your sample size before committing to a clinical trial. And I think in this specific scenario, it's almost all of these reasons combined that led to our choice of this research design.
Jinlai, do you want to follow that up?
Yeah, totally. I totally agree. I like to hear you said RCT is not necessarily the best way to study this subject. Totally agree. There's limitations, advantage from large retrospective studies and prospective studies into the RCTs. But I have a question. A big issue with studying NSAIDs is that they're available over the counter without a prescription. And how are you going to account for this in your study? Also, in the study, you are looking at the claims, but the claims meaning that the patients are given the prescription. That doesn't mean they took it. And how many pills they take it? They take one, they take zero, they take all of those?
That's maybe a two-folded question. Maybe Nasser could address the part about the database and claims first, and then I'll address the second part of it.
Yeah, so Dr. Lee, that's an excellent question. I guess first, to go back to the databases. These databases are great because they're structured around medication claims and then you have diagnostic claims. So what's great about the Pearl Diver database that we use for our question is that, one, there's large numbers, right? Numbers are always great. But at the same time, what you need to be concerned about with numbers is you want to make sure the data is validated. The Pearl Diver database is unique in that the data as it's entered by the Pearl Diver team is it's adjudicated and validated data. There's other sources of this data as well. So MarketScan, the IBM MarketScan database is out there. Epic has its own database now too with Slicer and Dicer. And these are great databases that can be used as well, but they all come with limitations. I think the limitations of all databases is that, one, is the data reliable, right? I may think it's fine. You may think it's fine. Dr. Mariano may be like, yeah, this is the best. We've coded everything perfectly. But the biller or the adjudicator may be like, no, this is not the right ICD code, or this is not the right CPT code. So there's always that level of variation with database research that you need to have some skeptic around. The second thing for Pearl Diver that's a bit of a limitation, I think, is you don't get patient level data. With the MarketScan database, you may get an Excel sheet of all the different patients and what with the Pearl Diver database, you get aggregate data. And that's because of HIPAA policies or HIPAA laws. So from that standpoint, you really need to be sure of your research question because it's all based off aggregate data. For your question, to your point about the NSAIDs, I think that's an excellent point. However, the researchers, the preclinical work suggests that even one dose of that NSAID can lead to that sort of inflammatory blunting. So the number of doses in this situation, we assume that it's continuous claim. If someone has a prescription for or a claim for an NSAID, which is how these databases are structured, you're assuming that claim isn't just for one day. You're going to assume that it's a continuous claim for at least 30 days, which is what typically prescriptions are prescribed for, right? 30-day prescriptions or 31-day prescriptions, monthly prescriptions. And that's what we adjusted for in our analysis to ensure that the claim was actually continuous throughout their 30 days. That wasn't just a random one-time use. We also adjusted our analysis to ensure that the prescription was either started or that the patient had that prescription filled within the 30 days before surgery, ensuring that, yes, they had some sort of NSAID in their system at that time. So again, we assessed a variety of different NSAIDs, not including opioids combinations, just NSAIDs alone. So the assumption we're making here is that the patient's taking that NSAID. But again, you can't be certain, right? And another assumption we're making is that it was a prescription NSAID. I think that's especially important because I mean, I could take ibuprofen at home, right? It could be a non-prescription NSAID, but we're assuming that this is prescription NSAIDs that are given to the patient. So stronger NSAIDs like naloxone or Totalac, things that are prescribed that the patient can't get over the counter.
Very
And
good.
over-the-counter NSAIDs are also a considerable issue in this study that really had to be addressed in a convincing way before making any conclusions. And over-the-counter NSAIDs are not going to be captured in this database. However, I'd like to look at this question of the over-the-counter NSAIDs from a different perspective and ask the question, so what?
Yeah.
Let's arguably assume that the non-NSAIDs arm had over-the-counter non-prescription NSAIDs, while the other arm, as per our selection criteria, had prescription NSAIDs. But despite this contamination, we could still detect an association, higher odds of between using bigger gun NSAIDs that are prescription and continuing opioid prescription at 3 and 6 months compared to what we arguably designate as a potential over-the-counter NSAID in the non-NSAID arm. And this argument kind of supports the result, the fact that we could still detect the association despite the presumptive presence of over-the-counter NSAIDs in the non-NSAID arm.
Yeah.
Now, the second argument about this answering to the over-the-counter NSAIDs is a little bit more complex, and it took us some time to design and confirm that it addresses our concern about over-the-counter NSAIDs, and it revolves around the use of paracetamol or acetaminophen and not NSAIDs. So we used paracetamol as kind of a control where we repeated the same type of analysis in opioid naive patients. So we had patients who were opioid naive, did not receive any NSAIDs, and we looked at peri-operative acetaminophen or paracetamol 30 days before or 30 days after surgery, and its association with continued opioid use at 3 and 6 months. And we chose acetaminophen because, one, it's a pain medication, two, it's an over-the-counter medication as well, exactly like NSAIDs. And this means the arm that should not have paracetamol or acetaminophen might still have over-the-counter acetaminophen. So a similar phenomenon of contamination, if you would like to say, would happen. Nonetheless, we could not detect an association between perioperative use of acetaminophen and long-term opioid prescription. So this is a phenomenon unique to NSAIDs. And that was quite tantalizing when we arrived at this assumption that this is just the only pain medication over the counter that causes such a long-term dependence, and it's not extrapolatable to paracetamol. And still on the topic of paracetamol, I'll deliberately digress to see if our findings are kind of watertight. And here we'll address the elephant in the room, so to speak. And that's the possibility that it is not NSAIDs causing this dependence, but NSAIDs are actually a surrogate measure or a marker of more severe acute pain. So what is causing this long-term dependence on opioids is the severity of acute pain after surgery rather than NSAIDs. They get severe pain, they get NSAIDs as a additional pain medication, and that is why they have the pain. So it's the acute pain being associated with chronic pain. And this was the most challenging assumption that we had to face. But again, the paracetamol analysis was very helpful because in this particular population, we hypothesized that if you have had total knee arthroplasty and you need additional pain medication, your surgeon or anesthesiologist or pain physician is going to rank paracetamol as an option before NSAIDs, primarily because in the perioperative period, you're going to be on long-term anticoagulation. So they would not favor that prescription of NSAIDs over Tylenol. They would probably, you will be having Tylenol or paracetamol as a first option, and then NSAIDs, and as well opioids for breakthrough pain, as we usually practice in our multimodal analgesic approach to pain management. So I would then expect paracetamol, since it's going to be the first medication I go to have a stronger association with chronic pain or with opioid dependence than NSAIDs. However, there was no association, which again feeds into the same conclusion that this is an NSAID-related phenomenon.
That's a really good explanation, just because I think one thing I appreciated about reviewing, handling your paper was just the explanation of why you did the sensitivity analyses. And I think that was really important. I recommend that anyone who's interested, even if this topic isn't the most pressing, but if you're interested in this type of research and the methodology, I found your description and the methodology just, I think, very clear. And I think it also shows that that researchers who are really focused on trying to answer important questions that might apply in clinical practice, you're the biggest skeptics of your own work. So you already look at these and try to decide, like, does that even make sense? And I think that it really fights, your explanation is great, because I think it fights against, I think, the bias saying, oh, well, you're just like throwing out, everything that sticks to the wall. What I'm saying, we've all heard it before, but you're very thorough. And said, before you put out any conclusions, you really wanted to test those things. So now, I think now that you've shown this association, between the presence of perioperative prescription NSAIDs and the continued prescription of opioids at 90 and 180 days after total knee arthroplasty. And this is one of the most common surgeries performed around the world, and definitely here in North America. How have you changed your practice, or have you made any recommendations to any of our colleagues as to how you apply those in your practice?
Very important question. What we detected, Ed, is probably a strong and concerning signal in the noise. We identified an association that was robust to sensitivity analysis. However, it should be clearly acknowledged that this is not a causal relationship. Causal relationships are derived from a different research methodology, primarily the randomized control trial. So while our findings are novel, they should inspire additional research before talking about real changes to clinical practice. In fact, the last thing we want to see is giving practitioners the impression that they should stop using NSAIDs to reduce the risk of opioid dependence following knee arthroplasty. Eliminating NSAIDs may mean worse acute pain and greater reliance on opioids for management of acute pain, both of which are predictors of the same outcome, i.e., increase in continued opioid prescription at 3 and 6 months post-operatively. So we would be shooting ourselves in the foot if we do that. So I think for applications, I'd say if additional confirmatory research results become available, a reasonable modification to practice may be stratifying or identifying patients who are at a higher risk for developing persistent post-surgical pain and having an informed discussion with them, and perhaps consider greater role for regional anesthesia and adjuncts in such a patient population.
Yeah, I fully agree with this, because I mean, just today I got a text from one of my friends at an orthopedic center who's and he's like, what should we do now with these NSAIDs? And I think you have to take it as a case-by-case basis, right? These questions are hypothesis generating. They're not hypothesis confirming. And I think that's especially important for database studies, because it just generates a signal. I think Dr. Abdullah said it perfectly, where it's something that warrants additional investigation. The preclinical evidence is saying something. You have database research that's saying something now. Now you really have to take it to the next level across the evidence pyramid and see if if level 1 evidence or level 2A evidence takes it to that same type of level. So I definitely would agree with that.
So let's coming from where we are now, going to your next steps of your study. Now you answered, you tell us there's a difference between prescription NSAIDs and over-counter NSAIDs. So with your next step studies, are you to look at the duration, the strength of the NSAIDs, whether or not we should use them, when should we start, when should we finish? What are your next steps of your study? What are your thoughts about the editorial accompanying your article?
Yeah, that was actually a nice editorial that I enjoyed reading. It was very well written, and I think it laid a reasonable roadmap for future research. I'd say that our research detected an association that needs to be confirmed using other research methodology. And the baseline is our research is based on claims data, and inherent to it is the assumption that whatever is claimed is consumed. But these are still assumptions that limit the role of this type of data. I think the most pressing item on the research agenda is to check whether a similar association could be detected when other anti-inflammatory medications are used. And here I refer to the family of steroidal anti-inflammatory medications, not the non-steroidal. If inflammation is truly necessary for healing, then steroids, when used to suppress inflammation, should theoretically be associated with continued opioid prescription at 3 and 6 months. I think reproducing our findings, hopefully, with this family of medications would be our next priority. And also, I would think about checking for dose response with NSAIDs and also the duration of exposure as factors determining the strength of the association.
Nasser, anything to add?
No, that was perfect. I think, the editorial was nice. It painted a great picture, and I think the flow diagram was just perfect. I think it really showed how you conduct a well-designed retrospective study for using database claims. And I think the authors of that editorial really nicely paint that, yeah, you need to check this association with other factors, steroids being one of them. I think that's a strong anti-inflammatory that needs to be assessed. We give steroids in the chronic pain world, intra-articular, all the time for patients with knee pain. And are we doing a disservice? Possibly. You don't know just yet, but I think assessing that in conjunction with other medications and other predictors of chronic pain after knee surgeries is important.
Well, thank you so much. I think, if anything, I am reassured that personalized medicine is alive and well. We are still learning about all the different factors that may predict chronic pain after surgery, as well as persistent opioid use. I agree with you 100%, Nasser, that we don't necessarily know all the factors, but I think we're learning. I think that your body of work, I think it really helps contribute to our understanding. And it also now, especially in an age where we've been starting to develop more access to electronic records, we need to start using that information to help tailor the care of patients who are having surgery, especially when we can plan ahead, weeks to months in advance, especially for scheduled arthroplasty. I want to make sure that everyone is again aware that we have this fantastic paper available online now with an accompanying editorial, and this is freely available for you to access and download. And thank you so much for joining us. I want to thank our panelists, Nasser and Faraj, as well as my guest co-host, the amazing Dr. Jinlei Li from Yale. Thank you so much for joining us again on the Anesthesia Journal podcast, and hope you join us again.
Thank you so much, guys.
Thank you for publishing our work and for this amazing opportunity. It certainly increases the impact and visibility of our work published in anesthesia.
Congratulations. Strong work on the paper.